So this meeting is organized by Infectious Disease Alliance, IDA, and my name is Kåre Mølbak, and I'm honored to moderate part of this event, and then later I'll turn to Carl Arjan from IDA, who will moderate later on. We have an interesting lineup of speakers for this event, and I think we are about to start. Hvordan ser det ud med, at folk kommer ind? Okay, people are still in the lobby, but I think in order to respect the time, because we have many speakers today, as you can see from this busy agenda, I'll introduce Rodrigo Scottini, who's the Executive Director of the Infectious Disease Alliance, and he'll give a few words about AMR and also a short introduction to IDA. And then we have 8 key speakers afterwards. But Rodrigo, up to you.
Thank you, Kåre. Thank you everyone for joining this event today, the ones online and the ones here at the Stikkenserum Institute in Copenhagen. I'm the Executive Director of the Infectious Disease Alliance, which is a newly established global health advocacy organization. Today we have this event on AMR, which has, of course, increasing importance both for the scientific and policy community. And I would like to address a couple of words to you today. So AMR is, of course, one of the most pressing global health threats of our time, endangering modern medicine, food security, and environmental health. AMR is an escalating global crisis that threatens to undo decades of progress in modern medicine. AMR is a complex issue that requires a One Health approach, integrating actions across human, animal, plant, and environmental health sectors to achieve sustainable solutions. Without urgent intervention, drug-resistant infections could cause 10 million deaths annually by 2050. Overuse and misuse of antibiotics in human health, animal agriculture, and environmental contamination exacerbates resistance. Innovation in new antibiotics is stagnant, hindered by broken economic incentives and market failures. Low and middle-income countries struggle with equitable access to effective antimicrobials, worsening global health disparities. World leaders have committed to reducing global deaths associated with bacterial AMR by 10% by 2030, as outlined in the 2024 UNGA Political Declaration. To accelerate action and increase impact, we must act now. IDA urges government, industries, healthcare professionals, researchers, and civil society to adopt concrete evidence-based measures that align with the One Health framework. Our target recommendations for policymakers, governments, and European Commissions include a transition from a market-driven exclusivity models to milestone-based funding and pooling incentives that reward innovation at critical R&D stages. Establish a cross-country pool incentive framework balancing push and pull incentives to predictable, sustainable funding. Foster public-private partnerships and new discovery platforms that integrate knowledge-based drugs discovery to overcome permeable barriers in bacterial cells. Promote global collaboration strategies to ensure incentives align with international efforts to make antimicrobial accessible and sustainable. The Infectious Disease Alliance also invites scientists, healthcare, veterinary professionals, and civil society to take a decisive, unified action against AMR, which will be discussed in call to action in the closed remarks later today. The event reflects our dedication to promote equitable health solutions and are committing to fostering ongoing collaborations and actions beyond the event. By maintaining active communications, fostering collaboration, and holding ourselves accountable to measurable goals, ITA aims to drive sustainable impact, and empowered stakeholders to take meaningful action against AMR globally. Together, we ensure the fight against AMR remains a priority across all sectors. So to maintain momentum, I invite many civil society organizations present today that are working in this area to join our alliance as members. And they could also be for research institutions, patient organizations, and civil society in general. So I'll say a couple of words about IDA. As you have heard, we are a public health advocacy organization dedicated to addressing pressing challenges caused by infectious diseases. Our vision is to reduce the burden of infectious diseases and improve access to healthcare. And our mission, as I said, is to unite civil society. So what we do, so we advocate for impactful policies and sustainable finance. We work on to unite civil society to combat infectious diseases. We promote healthcare system strengthening, so not only working in silos, but working in general to build healthcare system capacity, fostering cross-sector collaboration, and promoting equity and amplified underserved voices. What we offer to members, so access to critical tools, opportunities for global alignment, to improve their advocacy and policy capacities, partnership building, and resources. So partnerships is a very key approach to us. We believe that only together we can make a change. Specifically on AMR, we are part of the European Public Health Alliance's AMR network. I don't know if some of you are aware of that. It's a European platform for civil society to work on AMR. We're currently discussing the decision from the European Parliament for antimicrobial incentives, and we'll make a proposition for the civil society side that will come soon later this year before hopefully the Council can take a decision on antimicrobial incentives. So we have also here the list of type of organizations who can become members and the type of supporters and engagement actors. For membership, we can see here the benefits. Please also visit our websites. The areas we work on are those. As you can see, it's a very detailed kind of list of work, since we want to cover all the infectious disease areas, not leaving anyone behind. Events, you can see here some of the large face-to-face events we're organizing this year. We have 2 events at the WHA, more generally on global health finance and primary healthcare. Then we have the European event in the European Parliament on the 10th of June on vaccine hesitancy. The UNGA event on universal health coverage and integrated primary healthcare. And we're going to continue the discussion on finance at the World Health Summit, and ending this with the One Health Conference in Brussels, following the Danish priority for health, which is One Health. So this is the list of AMRs for this semester. We're the 3rd year, and this organization. I'll not talk so much about us. I think you can read more on our website. And I believe it will be time now to start with the speakers. I'll give the word back to Paul.
Thank you. And the first speaker is Christian Müller, who will present from here at SSI. He's the Director of Veterinary and Quality Services of the Danish Agriculture and Food Council. Christian will talk about antibiotics and resistance in Danish pigs. So up to you.
Thank you for inviting me here. I look forward to discuss things here. I'm from the Danish Veterinary and Food Council. It's a kind of umbrella with 200 members from the feed and food, obviously farmers, organization, and so on. So we spread in that area here. A lot of policy, but also looking into data. It's very important, I think, to have this collaboration, even if we are policy makers, whatever, we are also to know that we should know a lot of the things about what's happening. So that's also my idea is that we should be more in a close collaboration with both researchers and authorities and also people here. So I hope you will see that when here. First of all, at least for the pigs, we can call it a kind of industrial way to make pigs. That's what we do in Denmark. We make about 30 million pigs per year. Half of them is sold as 30 kilogram to Europe, to Poland, to Germany, and the rest we have about that. 90% is exported. Yes, just I think I have too many slides. Sorry for that. I only have 10 minutes to do that. But you can just hear. You can see we in the lower end. You can see the red one. How much we use here compared to the other 27 European countries. Okay, it's a lower end. I don't say we don't have challenges. We have, but we're still at the lower end. The same we see here compared to some of the countries with a high level of pig production. We see here, you can see really a reduction here. Some very much for the last years. We are in the really low end here, together with Austria and Netherlands, and then some have challenges, some problems. And I think we can make a collaboration in that. To do, because we should go for a reduction. What we can see here is what was the goal here from 2018 to 2030. We should halve the amount of uses for antibiotics in European countries. And as you can see here, Denmark, we are already below this area here, both total and for pigs. So you could say we have no problems, but we do have problems. So we should still look what we can do to be even better in reducing the amount. So we have some tools. I think we have the vet stat here. I think it's been running for many years here, and it's a very good kind of data board, or we can call it a database here. So all the pharmacies and also veterinarians and also the feed mills, they should send in what the kind of number of drugs they use for each of the farmers. So they should send it in to know exactly from more or less day to day what is used in the different farms and to what for what reason, and also to the level of the age of the pigs. It's a very good database, and I think that's what's good for this tool is it can be used for several different people, researchers, authorities to look for regulations. It can be used by us also. It can be used by the farmers. They can see their own usage and compare it to others. So I think that's a good thing when we make tools that we can use it for different purposes and discuss it together if possible. Then we have used it here to make what we call for the pigs a yellow card. That means that we have set some limits for what can be used for these 1,000 pigs, and for the weaners and for the finishers, different amounts they can use. If they come beyond that, there'll be a fine. In the beginning, it can be we will ask them for the authorities ask them for an updated plan. If that's not helping, there could be increased supervision or visits by veterinarians. It's costly, and then a fine if they cannot follow that. And we have had experience in that for several years, many years here. You can see what the limit is now. We have changed that during the years, starting to the right, and then if we have we are asked to reduce it, we have used this here. And you can see there's still kind of what you call a spread in the green. So there's still possibilities to do some interventions, as I see it. We always discuss that. And right now we are actually discussing if it could be reduced. I'll come back to that. But you have this not only for the small pigs, but also for the sows and for slaughterhouses. Different amounts here. It's by the authorities, and we have to follow that. And there's this kind of fine if it's not followed. Then we see what's the problem in the Danish pigs. You can see here to the right is more or less the parallel, the group way to mitigate them is the most used here. So it's a lot of antibiotic used here compared to the parenteral use in other age groups. So it's the weaning pigs who have a big problem. I think more than half of what's used to pigs is used for weaning pigs. So we have a big problem there. And it also increased while we have to reduce the uses or withdraw or zinc in 22. It was forbidden by EU to use zinc at weaning, and we knew that would be a problem. So we had a lot of this practice before, and we should find out what could we do by the feed and so on. But anyway, it just increased quite a lot. And we can see here, what happened here, it was more or less the aminoglycosides that was used here from 22 when we stopped. In mid 22, you can see the amount of aminoglycosides was just increasing quite a lot. Yeah, we still have this also for 24 and also see 25. There you can see of what happened here when we look at the hemolytic E. coli in the pigs. That's most of the reasons for the diarrhea. When we look at at least if there are some pathogens, you can see that the amount of sensitive is really decreasing here after we started to use aminoglycosides very fast. So it could be biased a little bit because we get all this information from one laboratory. It could be only the farms who were sending in after they had big problems for a long time. So of course it's biased. And we also asked them for maybe another way to look for the surveillance of antimicrobial resistance. But I think it's biased quite a lot. So even if we have this problem, we realize we really have a problem. We have also some of this E. coli that are resistant to more than 10 different antibiotics. So we can see that for the last 2-3 years. You have a problem directly related to the pigs. See, it was see that it's not very good. Okay, but what to do then? Okay, so there was before the summer there was the Food and Veterinary Agreement from 24 to 27. What to do about this reduction of antimicrobials, and it was stated that we should reduce it by 8% from 24 to 27. And that's already 1 year has gone now. And we can say already for 24, we should, for 4 years, it should be 2% per year. It's 1.8, so we are behind already. So what to do? And we hope for assistance from authorities and also for ourselves. It's very important that we also do what we can do by ourselves. And we have, here you can see what the goal is for 27. The background is 2018, so we never reached that. We tried that actually, is asked for to do that from 29 to 22, also in 80%. You can see we didn't succeed that, so now we do it once more. Authorities ask us to do it here in 27. We should reduce it as shown here. So we have agreed. Together with our farmers, you can say that we should do something by ourselves. First of all, we can look at all the results in the VetStat. We have some access to it, not all of it, and we ask them to have more. Before, in old days, we had direct access, but now we have some GDPR problems in that, so we can see only a part of this persistent pattern, or the amount of usage. But we have enough, can get enough information so we can see what kind of farms make it good, so we can make a kind of best practice guidelines. Which if we go for that, just looking at the data. We can also look who are using vaccines, if they use coli or Salmonella vaccines, is that better, or is what kind of treatment do they use it for, and so on. So we can have a lot of this information, but only for looking at the data. We'll also include productivity, because it's all very important for the farmers. It's what they live on. Of course, they should also have, if we can look at and say, okay, if you do this and this, it's costly, but you pay off when we finalize, because you don't use so much antibiotics. So maybe it's a good way to do it for productivity. We have seen that already. And then we'll do some campaigns. We see it to the last year. We'll have our own labs, and we'll go more in details about what we do for the laboratory system. And then I have some pictures here to see here. Maybe it's not, you should not eat right now, but it's actually what we see when we open the pigs. And I think it's important that we look also. It's very, when we look for these new ways to go, it's always people looking for new diagnostics. Very, very fast, and diagnostics can be used outside in the herd, but it's still, we have problems to use that. Sometimes you really need to go and look for the dead animals, the pigs, and not only more than one per day per farm. Maybe you should send in several during half a year to be sure what's the problem. It's a little costly, but I think it's we're going in that direction. If it's possible, send in samples so we can look carefully about what kind of diseases. Is it like this? You see this open here, up front here? Is E. coli more or less? Sure it is. We look, of course, for virus factors also. Is this more dry thing? In 99% there are no pathogens. So we should look for hunger, cold, stress, virus with feed. So it's very important to have this way also in addition to diagnostics. Yes, yes, it's only then we had also our things we think that authorities could do. The yellow card we saw before, they are already, we think that's a good way because it can really reduce it, but they are only doing this, I think they're not ready to make this, the authorities, because they are working on it. We say, do it now because we are already behind 1 year. So we ask them to do it as soon as possible. We should also, this benchmark model, they should do it to compare who are doing what and what. Is also 1 year behind, it's only in 26, they'll start this. So we ask them to do it as fast as possible. And then I think I will not go into details about this, but it's of course a lot of things we ask the authorities to look upon, and we look and will like to discuss it with them about the zinc. Could use maybe a little bit more zinc at weaning, but then reduce it, the amount after they get bigger, the pigs. So the total amount is less than now, we can use that. And then we can reduce the weaning diarrhea maybe. All this kind of discussion we would like to have. So that's, of course, a collaboration between industry and researchers and authorities is very important. Have a good, but it could be better. Thank you.
Thank you. In the interest of time, we have to go on, although it could have been interesting to have a discussion of these insights into how the pig industry is trying to reduce. We need to go on to Caroline Noonan, who is a policy and science manager at the Alliance to Save Our Antibiotics. And the topic will be next step reducing European farm antibiotic use. So it's we still continue in this field. So Colin, who's online, it's up to you now.
Okay, so thank you. Thank you.
We can see the slides, so I'll just shift whenever it's convenient.
Okay, so if you could shift now, please. So the first question that I would like to, well, I'm getting a lot of, can you hear me now? Oh, yes. I'm sorry, I'm just hearing a lot of reverberation coming back at me, so I'll just have to go on. So the first question I would like to address is the question of whether farm antibiotic use is contributing to the resistance problem in human medicine. This question was reviewed by the O'Neill review, which was set up by the government in the UK, and it found that a very large majority of studies carried out by independent academics found that there was a link between farm antibiotic use and resistance in human infections, although this is sometimes denied by some industry representatives. So some of the infections where we have very clear and strong evidence that the farm use is linked to resistance in human infections is infections like Salmonella or Campylobacter. But over the last 15 years or so, we've also seen the emergence of what were formerly hospital superbugs, such as MRSA and Clostridium difficile in farm animals. And these MRSA or livestock-associated MRSA and Clostridium difficile strains have been shown to also infect humans and even cause deaths. Another bacterium has been E. coli, and if you could change now, please. Yeah, so an important example has been the emergence of resistance to the last resort antibiotic, colistin. And resistance to colistin was first found in China in 2015, in pigs, in poultry, in retail meat, and in human infections. And we know that this resistance was definitely due to farm antibiotic use, since colistin was not being used at all. It was not licensed for use in humans in China at the time. And subsequently, China banned the use of colistin as a growth promoter, leading to a large reduction in colistin use in livestock. And this was followed by a reduction in colistin resistance in human infections. Unfortunately, we continue to use colistin in livestock in Europe, although use has also reduced here. And colistin resistance is found in human infections in Europe as it is found elsewhere in the world these days. Next slide, please. So fortunately, we have seen some very significant reductions in European farm antibiotic use. In 25 European countries, farm antibiotic sales have fallen by 53% between 2011 and 2022. And some of the factors that have contributed to these fall include a greater awareness of the need to tackle antibiotic resistance, initiatives that have been taken in individual countries. We've just heard about some of the targets that have been set in Denmark, but other European countries have also been setting targets, or in some cases even strengthening their own legislation. But also there was a knowledge throughout Europe that stronger legislation to restrict the use of farm antibiotics was coming. And this was ultimately introduced after probably about 10 years of talk. It was introduced on the 28th of January in 2022. And importantly, some harmonized testing of, in particular, E. coli in livestock have shown that in the countries where there have been large falls in antibiotic resistance, we are seeing falls. Large falls in antibiotic use, we are seeing falls in antibiotic resistance as well. And it's also good to see that it's not just the overall use of antibiotics that has been falling, but also the use of the highest priority critically important antibiotics has been falling. Next slide, please. So the European regulation, which was introduced on the 28th of January 2022, has many important factors to restrict the use of antibiotics. Some of these include the fact that antibiotics can no longer be used routinely. Furthermore, prophylactic use, i.e. preventative use, can only now be in exceptional cases, and if you are to use antibiotics prophylactically, it can only be administered to an individual animal only. Group prophylaxis is now totally banned in the European Union. Now, metaphylaxis, which is a form of group treatment where some of the animals are diagnosed as sick and all of the animals are treated in order to prevent the infection, this is still permitted, but only when the risk of spread of an infection or an infectious disease in the group of animals is high and where no other appropriate alternatives are available. Now, the preamble, the text at the beginning of the legislation explaining why the rules are introduced makes it clear that, if we could just go back please, makes it clear that these restrictions should allow the decrease of prophylactic and metaphylactic use in animals towards representing a smaller proportion of total use of antimicrobials in animals. In other words, the part of the aim of this legislation is to reduce group treatments and have more targeted treatments towards individual animals. Next slide, please. So apart from the individual treatments being targeted, there are other reasons also why group treatments should be minimized. The European Medicines Agency has said that the impact on selecting for AMR is greatest when antibiotics are used for group treatments in animal feed, followed by group treatments in drinking water. And the impact on AMR is minimized when the same antibiotics are used for individual treatments. And what we also know is that the countries with the lowest level, the lowest proportion of their antibiotic that is made up by group treatments also tend to have the lowest levels of overall farm antibiotic use and of antibiotic resistance. Next slide, please. And this is shown in this particular slide here. So this is the data on European farm antibiotic use, where I put in red where the UK, because we are a UK-based organisation. The columns show the level of farm antibiotic use in terms of milligrams per PCU, and the red line above shows the proportion that is group treatments. And in fact, what we find is that in 2022, so after this new legislation was introduced, group treatments were still representing 85% of European farm antibiotic use. This is down from 92% in 2011, but it is still extremely high. On the other hand, if we look at the countries that use the fewest antibiotics, which are Norway, Iceland, Sweden, and Finland, group treatments only represent a relatively small minority of total use, about 10 to 27%. I believe that in Denmark, it's something like 58%. So group treatments are below average in Denmark, but still well above the other Nordic countries. And these huge differences in group treatments and in overall European farm antibiotic use show that most countries in Europe can still make very large reductions in their farm antibiotic use. Next slide, please. But this EU regulation also has implications for animal husbandry. The regulation says that antibiotics may not be used to compensate for poor hygiene, inadequate animal husbandry, or lack of care, or to compensate for poor farm management. And in our view, there's very little evidence that this restriction is actually being fully implemented in practice. The truth is that European farm antibiotic use remains highly intensive in many countries, with high levels of animal stress, poor hygiene, and many different husbandry practices which have been shown to be associated with higher levels of disease and antibiotic use. And yet, even though these practices are continuing, antibiotic use is continuing sometimes in the same way. So in our view, really, we need to be moving to improving animal health. And we need to be improving husbandry practices, or else this EU legislation will not be properly implemented as intended. So we need in particular to be using healthy and resilient breeds for all farm animal species. Data from the Netherlands, for instance, shows that fast-growing broilers use over 7 times as many antibiotics per bird as slower-growing breeds. We need to be improving hygiene, and we need to reduce stocking density and provide good enrichment. This has been shown to be associated with lower levels of respiratory and intestinal disease. We need to be providing access to the outdoors, as this can improve gut health and reduce stress levels. We need to be providing appropriate diets. We know that reducing protein or increasing fiber can in some cases help to reduce diarrhea and can improve animal health. We need to be improving... Sorry?
How come you guys didn't put it on the calendar?
We need to increase the minimum weaning age of piglets, in our view, to 35 days. We've heard how weaning is when lots of diarrhea problems occur and high levels of antibiotic use. And we know that in countries, for instance, like Sweden, where they wean later, they have far fewer problems at weaning. And we know that in organic agriculture, where you have to wean at 40 days, weaning is not associated with higher levels of antibiotic use. We need to end the tail docking of piglets, as this is is in theory shouldn't be permitted routinely anyway, and it is essentially associated with lower levels of husbandry. And the only way you can stop tail docking, which is to prevent tail biting, is to improve the conditions in which the pigs are kept, and this will inevitably reduce ultimately antibiotic use. And we need to end the use of farrowing crates. And my final slide, please. So we believe that stronger targets for reducing farm antibiotic use are needed. We've heard that the EU Farm to Fork has set a target to reduce farm antibiotic use by 50% between 2018 and 2013. This is welcome, but we believe that more ambitious targets are needed and are perfectly achievable. In fact, by the end of this month, the European Medicines Agency is apparently going to be publishing the first EU report providing not only data on farm antibiotic sales, but on antibiotic use by farm animal species. And we believe that this will enable us to then start setting better and more precise targets by farm animal species. So we advocate for targets to be set to reduce farm antibiotic use in each species to 30 milligrams per PCU and ultimately to 15 milligrams per PCU in the longer term. And this will mean reductions of about at least 2/3 from the current levels. And we also argue that countries should be aiming to reduce their proportion of group treatments to 30% from the current 85% throughout the EU. Thank you.
You have to say everything again. No one could do a slide back.
Yeah. Dominique Monet, you're welcome to speak now.
Thank you, Cora. Good to see all of you, even from far away. And thank you for the invitation. Yeah, we have this issue with microphone, but no echo now, so it's fantastic. My point here was to recenter the topic and focus on one area which is really of concern for us: carbapenem-resistant Enterobacterialis, the focus on Klebsiella pneumoniae, and the fact that most of them are healthcare-associated infections. Next, please. There were council recommendations that were adopted by the Ministry of Health in June 2023. And for the first time, they have recommended targets for antimicrobial consumption and for the incidence of bloodstream infection with various MDROs. And I will focus now on the fact that the ministers have agreed that by 2030, the total incidence of bloodstream infections for the EU overall with carbapenem-resistant Klebsiella pneumoniae is reduced by 5% as compared to a baseline in 2019. Very reasonable. There were other targets with reductions by 10% for MRSA, 15% for MRSA bloodstream infections, 10% by 2030 for third-generation cephalosporin-resistant E. coli. And the EU has been progressing towards those. But next slide, for Klebsiella pneumoniae that are resistant to carbapenems, this is what we get. I don't know why all the setup and the template for the slides is not working, but this is not the slides that I submitted. I'm sorry. Anyway, I will keep on speaking, and hopefully you will get the proper slide when you receive them. So what we've seen is between 2019 to 2023, the latest data that we have is an increase by almost 60% of the incidence of bloodstream infections with carbapenem-resistant Klebsiella pneumoniae. So definitely moving opposite the targets of a 5% reduction. Next, please. All member states have their own target. The reduction target depends on the incidence in 2019. And here we present the data in a bit in a different way than in the rapid risk assessment from the countries with the lowest incidence to the countries with the highest incidence. The other data that we present is we present the numbers, and these are the estimated numbers when we take into account coverage in the data that are reported to ECDC as part of EARSnet. And you see that sometimes plus one case minus a few cases result in a large decrease or increase. So it's important to have this. For Denmark, just having one case more means a 14% increase. So we need to be careful on how to interpret the increases. Still, you see that there has been a decrease in some countries, Finland, Ireland, and Malta. When you talk to those countries, they will say, well, okay, decrease, it's small numbers. There has been a decrease in bloodstream infections. But keep in mind that this is the tip of the iceberg, and there are many more other infections. In Ireland, it's 10 times more. And there are even more patients that are carriers of carbapenem-resistant Klebsiella pneumoniae. In Ireland, it's 100 times more approximately than the number of bloodstream infections. So this is just the tip of the iceberg. Second point I wanted to make. And then third point I would like to make, the data are not necessarily representative of the population in the country. There have been changes in methodology, except in France. So the only data available for France are 2022, and hopefully we'll have the update this year for 2023 and 2024. So many pitfalls. Look at the numbers at the other end, at the bottom right of the graph. Thousands of cases. And these are just with bloodstream infections. That means there are 10,000s of cases, maybe more, of patients that are carriers in those countries. So this has been an alert, I would say, for all the countries. And we decided to update our rapid risk assessment. Next slide, please. As part of the rapid risk assessment, we also compared the consumption of the carbapenems, of the polymyxins, mostly colistin in the center, and also on those newly approved antimicrobials with activity against CRA. And we put just a few of those that we know have activities against CRA. And you see the large differential in the EUEA hospitals, doctors still prescribing a lot of carbapenems and a lot of polymyxins when there are safer alternatives among the newly approved antimicrobials with activity against CRA. So that's another message, and these data are now public and they are part of the rapid risk assessment. And of course, this is an issue with access that will need to be addressed. Next, please. So we published the rapid risk assessment that includes an epidemiological situation, a summary of a risk assessment, and then recommendations from ECDC in various areas that I will review now. Next, please. So the epidemiological situation, carbapenem resistance in Enterobacteriales such as Klebsiella pneumoniae and E. coli poses a significant threat to patients and healthcare systems in the EU-EEA countries. Since 2019, there have been various signs that the epidemiological situation in EU-EEA countries is deteriorating. The signs include increase in the incidence for carbapenem-resistant Klebsiella pneumoniae bloodstream infections. And we've seen this in the data that I just showed to you. And this is, from our assessment, due to the continued transmission of high-risk lineages of carbapenem-resistant Klebsiella pneumoniae in hospitals. There are signs of convergence between virulence and resistance in Klebsiella pneumoniae, including healthcare-associated spread of hypervirulent Klebsiella pneumoniae ST23 that carry carbapenemase genes. And this has been reported by some member states, and there is a specific rapid risk assessment addressing this. There are newly emerging Enterobacteriaceae species that carry carbapenemase genes, among them Providencia stewarti, and there are other that have been named, and this is something new. They were not under surveillance with EARSnet, but we start in the event-based surveillance to have more reports about those. Plasmid-mediated spread of carbapenemase genes is causing outbreaks within hospitals and across healthcare networks. And finally, there is an increasing detection of isolates, including isolated cases, but also cluster of cases of high-risk lineages of E. coli that carry carbapenemase genes with a risk of spread in the community. And in this area, so then there's the impact of the war in Ukraine. After the start of the war in Ukraine in 2022, there have been importation of various MDROs, including CREs, into EU-EEA countries, and this has been documented in relations to patients from Ukraine being transferred. Nevertheless, our assessment is the high-risk lineages of carbapenemase-producing Klebsiella pneumoniae had been spreading in hospitals in the EU-EEA before the war, and that was documented from data from surveys that we've been conducting in 2013, 2014, and then in 2019. And then in addition, the cross-border transfer of patients with CRA occurs frequently between EU-EEA countries and from non-EU-EEA countries other than Ukraine. So it's just the warning that anytime there's a transfer of a patient between countries, there's a risk of also transferring CRA. And the measures that should be taken for patients being transferred from hospitals in Ukraine is the same. Next, please. So the risk assessment is the probability of further spread of CRA in the EU-EEA is high. This is not stopping, this is increasing. High level of attributable mortality of CRA bloodstream infections despite newly approved antimicrobials with activity against CRA. Infection prevention and control and antimicrobial stewardship can reduce the spread of CRA, but our assessment is that the implementation is suboptimal in many hospitals and has been insufficient so far to achieve sustained control of those high-risk lineages of carbapenem-resistant Enterobacteriaceae. The impact of further spread in the EU, if the spread continues, the impact will be high. If strong and consistent EU-EEA-wide national control efforts are implemented, our assessment is that the impact will be moderate. And if we combine probability of impact, well, there's a high to very high risk that this is an issue that will have a public health impact for the EU. Next, please. So our recommendation, you will not be surprised by the recommendation, but we'll try to list them here. Enhanced efforts are required to control and reduce the harm related to the spread of CRA. There's a need to strengthen national coordination of control measures between hospitals and regions and support to hospitals in the implementation of these control measures. We suggest, if it does not exist, a CRA management team, national, dedicated, multidisciplinary at the appropriate national level, and then a specific CRA management plan outlining the actions and budget with regular public reporting on progress. This can be, if there is a plan for antimicrobial resistance in general, this can be part of the plan. But there's a need, from what we see, of an urgent specific action for mitigating the risk linked to spread of CRA. And then there should be clear targets and with defined timelines as part of the plan. Recommendation on IPC and antimicrobial stewardship, implementation of enhanced infection prevention control measures in hospitals to interrupt the transmission of the CRE. These include preemptive isolation and screening for asymptomatic CRE carriage on hospital admissions for patients who have been hospitalized in a country or hospital with a known or suspecting high prevalence of CRE in the preceding 12 months. This is not something new for you in Denmark. It's something that most hospitals probably do already, as an explanation for the low rates of CRE in the country. Detailed IPC measures are outlined in the recommendation, and I will not go through them, but I will refer you to the rapid risk assessment. Apply antimicrobial stewardship to decrease selection pressure and preserve the effectiveness of the carbapenems and the newly approved antimicrobials. And this includes national treatment guidelines for CRE infections and audits of their implementations. Next, please. Genomic surveillance, laboratory capacity, innovation, and access. There's a need to strengthen genomic surveillance to guide the IPC measures by identifying the sources of CRE outbreaks and delineating the transmission chains. You have many examples, recent examples of rapid risk assessment provided by ECDC that actually were based on genomic analysis of isolates in these outbreaks. There's a risk for community-associated spread, and in this case, genomic surveillance is also required for E. coli that carry the carbapenemase genes, because we know that this is where we would have early identification. And from experience, we'll hear more and more about carbapenem-resistant E. coli in the 5 to 10 years. Adequate laboratory capacity for rapid detection and characterization to enable targeted use of the newly approved antimicrobials. This is essential. The newly approved antimicrobials have activity on some carbapenemase producing Enterobacterialis, but not on others. This depends on the enzyme produced, and this can be detected by identifying the gene that encodes for the carbapenemase. And then strengthen innovation and access to antimicrobials indicated against CRE infections. Next, please. Now, of course, infections with MDROs, and that includes CRE, result in substantial human and economic burden globally, but also for EU/EA countries. But our colleagues from OECD have produced a fantastic report, and you have a reference here, where they estimate that a mixed package that includes antimicrobial stewardship, that includes enhanced hand hygiene, and these two are focused on healthcare. And for implementation of €1, this mixed package would actually result in savings of about €3, with differences between countries. So these are results that we should put forward. Investing in infection prevention control and antimicrobial stewardship is cost effective and would result in savings. Next, please. Thank you very much for your attention.
Well, thank you very much, Dominique. And I think this perspective on the investments is really important. But I think that we should continue. And it's the next speaker is Chantal Morel, who is a health economist at the University of Bern. And Chantal will talk about conceptual challenges in the use of economics to support action in AMR. So Chantal, are you ready for your presentation?
Yes. Do you hear me?
Yes, we hear you.
Okay. I hear myself with an echo. Is it possible to mute whatever it is that's doing that? Okay, maybe that's been sorted. Super. Okay. Hi, everybody. I am going to be shifting your focus once again to some issues having to do with the use of economics for justifying action on AMR, but particularly in this case in the LMIC setting. So again, a shift of to another topic, but I think it's great. It really shows that, all the areas in which we really need to do more work to be tackling AMR. So the background here, clearly action on AMR in many, many countries is really slow. Most countries have a national action plan in place for AMR. They've agreed on it, at least 5 years ago. But in terms of the number of countries that are actually implementing these plans, it's really, really small. I think the latest figures from the TRACS survey from 2024 suggest that there are about 10% of countries globally that actually have any sort of a budget attached to the implementation of their national action plan. So it's really, it's really insufficient. So now, what can we do about this? Well, certainly to try to, increase or improve the prioritization of AMR, within, government planning and resource allocation, it's to do an economic analysis that basically looks at, what can we expect to happen if we don't do more to tackle AMR starting today? And so what would the economic losses look like compared to a situation where we implement a package of AMR interventions, look at the, the costs and the benefits from that set of interventions, and then see how much of that overall economic loss can be avoided. So these are sort of basic economic analyses. And of course, they're really important in the sense for, ministers of finance. They allow, AMR to be compared to other pressing, economic or political priorities. They allow us to compare things that are not usually very comparable because you're putting these things in, largely monetary terms. Also in clinical terms. I mean, you can keep things in terms of deaths or infections averted or whatever, depending on the type of analysis you use. But what they do is they improve comparability in decision making. Now, these estimates, so these types of studies have been conducted at global level. The World Bank did a big assessment, I think it was 2017, then just last year, the quadripartite. So the WHO, UNEP, FAO, and WOA did another assessment of the economic burden of AMR. And there was another one done by the Eco-AMR Alliance, also in 2024. And basically the conclusions are, the modeling that's done is quite different. It's set up in different ways, but the message is always pretty clear. Okay, if we don't do more on AMR, globally, we will have major economic losses, somewhere on the tune of $1 trillion lost per year to AMR, even as soon as 1 decade from now. So major economic losses. However, so, one could ask, so, okay, that's pretty clear evidence that, everybody needs to be doing more. But when it comes to many countries, it seems to not be a very convincing argument. Now, why is this? Well, for one thing, these are global estimates. So for individual countries, it's like, well, okay, that's, that's for, the world overall, but what about for us? Maybe that's not a potentially a sufficiently strong argument for action here. So there is an important point to be made here that we may need to be looking at estimates of economic impact at country level to speak more clearly, what is at stake with regards to AMR. Also, these studies have mainly focused on bacterial infections. And now that has made sense in the sense that they were kind of meant to tell the world how much this, this is likely to impose in terms of an economic burden, but mainly to speak to donors who are coming from the richer world where the main preoccupation is bacterial infection, and those becoming untreatable as we move on. But to many of these countries, so in many low and middle income countries, bacterial infections are not really what is known to be causing, the majority of deaths or infections. There's very little data, if not no data, in many countries on bacterial infections. And what is known is that we see people dying from parasitic infections, from viral infections. So here we are, talking about bacterial infections and the economic impact of resistance to bacterial infections. But really, what they're dealing with on an everyday basis is, infections caused by other types of pathogens. So again, perhaps not terribly convincing from taking action in some of these countries on bacterial infection. Also, clearly, I mean, there's many countries who don't have internally the money to be implementing their national action plans. There's no doubt there. However, there is funding being made available externally to tackle AMR, but it's just not being applied for. Now, why is this? For example, so World Bank is making money available, partly, I think, through its own direct funds, but also through the pandemic preparedness funds. But why are so few countries applying for this money? Well, part of it perhaps has to do with the lack of what I'm calling legacy prioritization, because a lot of the times to get World Bank type funding, you have to show that AMR is a priority for your country, that it has been, that it's very formally included on your 5-year health plans, and this has not been the case so far. So that's one thing perhaps that's missing. Also, it's not very clear for some of these countries if they have no data on resistance resistance amongst bacterial infections, then it's not so obvious what they're going to be using to inform some of these external funding requests. So I'll just leave this here, that there's some real technical challenges in countries accessing the money that is meant to be made available for NAP implementation, and that we may want to consider doing this a little bit differently. So for example, taking the approach that the Global Fund has been taking, where they basically have technical teams that work with countries in order to make a formal request for funding from the Global Fund. So it's people with very specific technical skills who know how the Global Fund works and the type of data that they need, the type of justification that they need to be able to give countries funding. And perhaps we should be doing the same thing for AMR. And we have not been doing that at all yet. Okay, so clearly part of this is a communication issue. We need to make sure that when we talk about AMR in most of these countries, we need to be making it broader than just ABR. Let's make this relevant to them. We need to be, including viruses. We need to be including parasites, even fungal infections, even though there's no data there either for most of these countries. But we need to be looking at this a little bit more broadly and really making it relevant to the specific epidemiological reality of those countries. Otherwise, I do not think we'll really make any headway in terms of prioritization of AMR. Also, one thing we could be doing is perhaps just shifting the focus a bit to a more general concept of treatability of infectious diseases. This is far more easy to internalize as a problem than ABR. So ABR being, a biological phenomenon that we're talking about, where there's a pathogen that has developed resistance to a drug to which it used to be susceptible. Anyways, it's much more convoluted to be talking about ABR or AMR. Why don't we shift the focus to something that people understand, perhaps treatability? This also would make things much simpler from an economic standpoint, to be able to look at the benefits from interventions, for sure. And also, it would allow us to include in our economic analyses very basic core interventions that we know are important for AMR, but that are also really important for all infectious diseases. So for example, WASH, right? Right now, WASH, we can't really include it so well within economic analyses that are focused solely on AMR. For one thing, there's a bit of a lack of data. So the main data we tend to look at is reduction in diarrheal infections in children. But that's a really, really small benefit to be accounting for all WASH. So that's it's too narrow. And unfortunately, it means that within the economic analysis, you have to take into account the full cost of WASH, but then only account for a very small amount of the benefit because you're looking to make it relate to AMR only. So it's really limited. So if you were to be broadening this out to a more treatability focused, perspective, you could include all the benefits associated with these really core basic measures or interventions that we need to be underlying everything that we're doing. Oh, my slide got a little bit messed up as well. Oh well, doesn't matter. Look, if you could just go back. Sorry, who's ever doing the slides? Okay, thank you. So just to say that by looking at this through a treatability lens, it then allows us to incorporate basically within our treatability equation, one could say, not only the type of pathogens we're talking about, but also look at, the degree to which we have diagnostic and prescribing capacity in place, access to treatments, so whether or not treatments are actually accessible to patients, that's even more important than, resistance in many ways, is actually the drug available to the patient. And then, of course, susceptibility to the available treatments. Anyways, I'm going to be talking about this more if anybody is interested at ECMID Global, I think late next month. And I'd be very happy to discuss it with anybody. But anyways, so I just kept this very, very short here. Next slide, please. So finally, when we're talking about implementation of interventions to tackle AMR, we should not be using a really narrow perspective like basically AMR as in its biological phenomenon, that like the framework that we use for research. When we're talking about implementation, we're really talking about much broader measures. And really, we must remember that we must take a systems perspective when we talk about implementation. So whether we're talking about, surveillance, laboratory capacity, or health information systems, we're talking about basically, all infectious diseases that can stand to benefit from them, whether these be bacterial infections, viral infections, fungal infections, parasitic infections. We can be tackling these using the same measures, almost identical. In the case of, stewardship, WASH, supply chain strengthening, limiting the use of antimicrobials in farming. Okay, that's a little bit different. But in almost all cases, we can be tackling things properly from a systems perspective and achieving gains across the infectious diseases. One place where it's a little bit different is in infection prevention and control, of course, where some measures are the same and some are different. So for parasitic infections, we may be talking more about, community-based measures, especially where it's, related to vector control. For fungal, we may be talking more about the use of like azoles in farming, on a large scale. So these are different to some degree, but many can be captured very much with a systems perspective that is infectious disease wide. I think it's my last slide now. Next slide. Yeah. So thanks. Again, this is a bit of a mini presentation on something that I'm going to be showing in much more detail at the end of next month if anybody wants to look at this further. Thanks.
Thank you very much, Chantal. I think this was very interesting, and it also this issue about treatability actually links very well with health systems and health systems strengthening, and in order really to target AMR. we need resilient health systems to accommodate all these issues. Okay, I'll leave the floor now and let Carl chair the rest of this afternoon session.
Hi everyone, it's my honor to continue the moderation of the event. Now we have Dr. Danilo Lafovong. He is the regional advisor for the control of AMR at the World Health Organization, European office in Copenhagen. Danilo's topic will be about roadmap on AMR for the WHO European region.
Thank you very much. And thank you very much for having me. It's a great pleasure. I saw a lot of former and current colleagues are here, and I was looking forward to seeing them again, but also forward to meeting new people. So I've been asked to give you a little bit of an introduction to the roadmap on antimicrobial resistance for the WHO European region, which, as many of you will know, is 53 member states, so twice the size of the EU, EEA countries that we have on the continent, and how we are trying to go from evidence to action. And I'll try to stick to my 10 minutes. I know we're already quite late. But first of all, a little recap on why, what are the key challenges to actually achieving impact at a country level? We've been hammering at this for many, many decades now. So I think one thing that Chantal was actually mentioning just now is the AMR narrative itself. I mean, we still have difficulties in how we present antimicrobial resistance as an issue that affects us all, and to highlight what the issues are that we can do. There's also, despite a lot of high-level meetings and declarations and action plans, there's still a lack of true leadership. I mean, it's easy to vote for a declaration or for a resolution, but what do you do in your country? How do you organize the different sectors, and how do you actually move forward with action? Part of that is also the complexity of antimicrobial resistance. And we heard from Christian, we heard the issues in pig farming, we heard agricultural issues, there's environment, there's human health. Complexity of antimicrobial resistance actually requires that different sectors work together, which is very difficult because governance structures are not geared to that. We're not geared to talk to other sectors. It's not natural, also because funding flows are different. Plus, there is no definite accountability. There is no consequence for not making progress, for failing, basically. That's one of the other issues. Chantal mentioned that like 10 or 11% of global action plans globally do not have a dedicated budget. In the European region, this is 30%, which is a little bit better, but still quite worrisome. Of course, what are you going to do without a dedicated budget? A lot of things can be done, a lot of things are being done, but they're quite ad hoc and random and not necessarily connected. The other thing is that we've been working on this for many decades, especially a country here like Denmark. The first Denmark report is from 1997, which was already accumulating a lot of interest from before that. So a lot of things we know what to do, we're just not implementing them. Why is that? And then finally, of course, most countries in the world have a national action plan, beautiful documents, which exactly say what needs to be done, but not necessarily by whom, by when, and etc. So there's a lack of operational plans and also a lack of harmonized indicators. So if you don't know where you're going to, how do you know when you get there? And finally, there's still a shortage of qualified staff. I think antimicrobial resistance in many countries does not fill a lot in the curriculum, both in veterinary studies or human health studies, etc. So we all thought that this was incentives enough for us not to do another global or regional action plan when ours expired in 2020 during the COVID pandemic. But we wanted to do something else. We wanted to make a roadmap and basically gather all the evidence that is already available for countries to choose from. Now, I'll quickly run you through it in the interest of time. Of course, we have a vision which says that by 2030, which actually is an arbitrary date, but it's also the date when the SDGs end. So it's a good time to
stop and look where we are. By 2030, people and animals are safe from hard-to-treat infections in healthier environments. Now, in our vision, we mentioned humans, animals, and the environment. That is already sort of the first hint at our first principle is to look at health through the One Health lens. We also mentioned the term hard-to-treat infections, or as Chantal called it, treatability. This brings the discussion more to people, so have a people-centered approach. It's very important to look at bug-drug combinations, and Dominique showed you a number of these facts, like these are the trends, these are going up, these are going down. But ultimately, what we really, if we want to reach people, basically tell them that this is about the ability to treat. So hard-to-treat infections, to bring the discussion back to a people-centered approach. Equity, of course, extremely important. There's a lot of inequity, not only in our region, but also globally, and have a more of a systems view. So not look at these separate sectors, but, or even within a sector, have a more holistic view. So those are the 4 principles of the roadmap. Then we have 3 major outcomes. The first one is related to prevention, the second one related to control, the third one related to treatment. Now, I don't like to use fighting and war rhetoric when it comes to AMR. There's a lot of combating AMR out there. I don't like that. But honestly, these are the 3 lines of defense, if you will. First control, first prevention, not then control, if not then treat. And then we've basically have these 53 evidence-based interventions that we've identified in broad consultation with experts and colleagues from around the region on what we already know can be done. And then basically the action areas and the enablers are a way of grouping these interventions. We have 5 action areas that are color-coded to these 3 outcomes. The first 2, prevention and control, and environmental and social determinants are linked to prevention. Here you can see already the fact that we include environment and social determinants. This is already an expansion of what normal action plans look at. This is something that we were advised by through many consultation, that a lot of factors in there that are influencing antimicrobial resistance. And the second 2 action areas, prevention, stewardship, and community awareness and enabling behaviors, have of course to do with control. And finally, access to medicines and health products, which include diagnostics, etc., are linked to the ability to treat. Then we have these 6 enabling areas, like governance, legislation, laboratory. We were advised to keep that separate. Of course, it's a huge area that goes across many things. Surveillance, workforce, extremely important. And also finally, a little bit of a mixed pot on research and innovation and digital technology. Digital health is the. I will not go into detail in what's in these different boxes. You can find it online, and 10 minutes is just not enough to present that. I would like to direct you to a resource guide that we developed in relation to the roadmap, where again you have the action areas and the enabling areas. It's an interactive PDF. So if you open the document, you can click on any of these action areas and you go straight into the chapters that are dealing with this. So here on the left you have the interventions, then you have the suggested actions and the rationale for these actions. And on the right-hand side, you can also see, again, an interactive bar that takes you through the different action and enabling areas for the details. And in addition to that, we also have different chapters about partnerships and how to set that up. And also we have a glossary of terms. I think that's important because we are dealing with this with different disciplines. At least they need to know what it is, what we mean with different terminology. There's a link to other key initiatives, and I think this is important. This is not a document that is trying to capture everything, but it's also linking to other things. Like there's an immunization 2030 agenda. There are other major, let's just say, discipline-specific strategies, etc., that we are linked to here. So it's not comprehensive in that sense, but at least it's a bit of a one-stop shop. We also have personal stories. I think this is something that we've been doing increasingly. I brought a few copies of our Stories of AMR book here, not for everybody, but first come, first served, where we collect stories from around our region. So It could be patient stories or survivor stories or healthcare workers, but it could also be others, like a restaurant owner from Georgia, a lawyer from the Netherlands, a psychologist from Bulgaria. Everybody who has any idea or any meaning about or any feeling about AMR, they're welcome to share. We keep sharing these stories also every week on social media, in the hope, of course, that we talk to, or that you read something from a person that you relate to, and you start thinking about AMR. We also have a lot of case examples in this document, bringing AMR in the context of other major issues, such as the humanitarian context, climate change, housing, private sector, wastewater surveillance, companion animals. We have a number of country experiences because this is very important for countries. We always get the first question, which country is doing the best? Which country is doing the worst? And of course, we would not necessarily go into details about which country is doing the worst, but we are trying to share examples, especially of good examples. And of course, the references to all the interventions that we are suggesting. This is basically, I guess that's the gold mine, if you will. This is where the evidence for the suggested interventions are listed. And it gives, of course, a bit of a snapshot. But I do want to say that the roadmap is exactly that. It's a roadmap. It's not a comprehensive recipe for how to set up an AMR program, but it's more of a menu of the things that can be done. In relation to that, we turned the roadmap into the AMR compass, which is exactly what it is. It's trying to do that. It's trying to guide countries in a certain direction. You'll see the whole roadmap is there. You have the 4 principles in the middle. You have the 5 action areas around that, and then you have a circle of we call enabling areas there. The compass is a tool, still developing. It's not completely ready, but that helps countries assess their national capacity in these different areas. And then within that, based on that assessment, countries can identify the national priorities. Again, not to try and do everything, do a few things and do them right. Then you can set national targets. By 2030, we want to be here and here with infection prevention and control in healthcare in healthcare settings, for example. Then you can use the associated interventions to implement these priorities, if you will, and then use the same process for monitoring and evaluation. So I'll leave it at that in terms of the roadmap. There's a lot more details, of course, that can be shared. I also wanted to quickly leave you with a little bit of an overview of some of the latest things that we brought up. Not to go into details, but we have these 2-page advocacy materials where we basically put AMR into context with another topic, such as cancer, such as food safety, such as health workforce, etc. To combine these different areas. We have a quiz that I would suggest you take. You can take it on your telephone, but I would suggest to do it on a computer or tablet, something a little bit bigger, and put the sound up. We've also started looking at building the evidence for phage therapy. It's a discussion that's been dormant for a long time, and we want to see how we can gather the evidence and make it part of the arsenal against antimicrobial resistance. We looked at knowledge, attitudes, and behaviors, which is basically an expansion of the Euro surveillance survey that's being done every 2 years in the EU. Same with AMR and antimicrobial consumption surveillance reports that gather the whole region beyond the EU, EEA. Doctor-patient dialogue is an example of how we take a people-centered approach where doctors and patients can have to co-create the treatment, which does not necessarily involve using antibiotics, and etc. In the interest of time, I'll just move on and leave you with, I guess, something we can all agree on, that AMR is everybody's.
Thank you, Daniel, for sharing AMR roadmap. Now we're back to Sweden again. This time we have Dr. Andrea Caputo Svensson. He's the Global Health Advisor at REACT. Andrea's topic will be about antibiotics and resistance in sustainable access to effective antibiotics and end-to-end approach to R&D.
Thank you. Thanks for inviting me and inviting React to speak today. An excellent panel. And I'll switch the topic again. We're still going to talk about antibiotic resistance, but I will look into more R&D, so research and development of new antibiotics and how we can achieve sustainable access to effective antibiotics. Next slide, please. Before diving into the topics of today's presentation, I wanted to introduce you to React. For those of you who don't know our network, we've been establishing in 2005. So this year, we're actually celebrating 20 years since our foundation. And we've been focusing on antibiotic resistance since the very beginning. We're now spread over 4 continents, where I'm sitting in Europe, in Uppsala, Sweden, and also offices in Asia Pacific, in Africa, and in Latin America. We work both with communities, but also we provide technical support to countries and do advocacy and policy at different levels. Our core financing comes from the Swedish International Development Agency, SIDA, and our vision is a world free from untreatable infections. Next slide, please. As I was just mentioning, 20 years of work that React has been in this field and specifically in the R&D space. And I'm not going to go through all the details of the different milestones, but I wanted to just highlight a few of them to really understand how we came to the vision, the approach that we're proposing today. Starting from the 2009, I heard before also a colleague from ECDC, and one of the report published in 2009 together with indeed ECDC was the bacterial challenge, time to react. And at the same time, the same year, there was the EU Swedish presidency, where we've been discussing innovative incentive for effective antimicrobials. Those discussions led to a bigger conference in Uppsala in 2010, and most importantly, in 2016, with the UN high-level meeting, where the inclusion of the word "the linkage," which I will explain in the coming slides, was included in the political declaration, and this came indeed from a strong push from React. In 2021, we published the end-to-end report, which is I will also present it later on, and all of these had the trickle effect in how the narrative around the R&D space was built for React up to 2025, so early this year, where we published a new policy brief on how to achieve sustainable supply chain. Next slide, please. So here, the end-to-end approach that I mentioned before, and as the word said, is indeed about taking an approach which is comprehensive, it's holistic, and it can be divided into 5 challenges, if you wish, or 5 solutions that goes from research priority coordination up to ensuring sustainable access in different countries or in all countries. And those challenges, as you also see from the image, they are interconnected with each other, which also means that in order to ensure sustainable access to effective antibiotic, those steps need to be already taken into account into the early stages. Next slide, please. So now we're going to go into the more details of each of these steps. Starting with the research priority coordination. Over the years, we've been seeing that research priority was mostly focused where the market, where the funding were. So disregarding or overlooking what actually were the global health needs, specifically when it comes to LMICs, so low middle income countries. Whereas we believe that it's extremely important that this gets more balanced, and in order also for addressing the global health needs, we do need to look into what are the global priorities and address them also from an R&D perspective. Next click. Second point is stimulating early discovery and research. I think this is extremely important. There was some mentioning from others before, but I don't think it's spoken enough about how, unless we resolve scientific challenges, we cannot pull through the antibiotic chain any good molecule. So it's extremely important that those challenges are looked into. There are fundings that allow indeed researchers to look into these challenges and solve them. We had a workshop specifically discussing it with 15 major experts, and I encourage everyone to look at the report. There is both a longer and a shorter policy brief where there have been listed a few solutions to how to move forward also when it comes to early stages of R&D. Next slide, please. Another important point is definitely financing the later stages of R&D. There is a lot of discussions about pool incentives, and I think it's extremely important the linking the R&D costs from sales revenue. So the linking is the word I was using before that was already previously adopted in the AMR political declaration back in 2016. And what it means is basically that, as you can see also from the image, I think you can do another click here. You see the difference between what it means when all the revenue basically comes to the part of R&D and then is reflected also in the prices and in the sales of volume for the antibiotics. But we want to break that link because we believe that those costs of antibiotics or getting access to antibiotics shouldn't be connected to what's actually important by developing into the R&D space, so the previous stages. So it's extremely important to make this different and to break this link. Next 2 clicks. So what we're proposing, or what we have been proposing over the years, is what is called the milestone prices, which is a way to incentivize the R&D through different steps in the different milestones, and this has been proven to be rewarding in the end. And also when it comes to a price perspective compared to billion-dollar market entry rewards, or TV, the milestone prices are around 24 and 46 million US dollars. So we're cheaper than this. Next slide, please. What I was mentioning before about the latest policy brief that we published on the sustainable production of antibiotics, we try to list what are the current challenges and what can actually be a solution to that. Some of the challenges here was indeed the lack of transparency when it comes to manufacturing of antibiotics, and how it's extremely hard to know what is the extent of API, so active pharmaceutical ingredients, which are released into the waters, and how those can have a trickle effect towards the animal sector and eventually also to the human sector. What is also another important point that we made here was the lack of a sustainable tech transfer between high-income countries and low-middle-income countries. And this is extremely important because, as we know, some low-middle-income countries might have weaker regulation than high-income countries, and this shouldn't be just a solution from a high-income country perspective to just move all the production to LMICs, without instead also respecting what could be the effect and consequences of this production, which is not regulated in those countries as well. So it's extremely important that we keep raising awareness on this topic, which is one part of the chain, but a very important one. Next click. As I mentioned at the beginning, access without excess has been our motto for now several years, and I think really summarizes the principle of ensuring that everyone in need has access to effective antibiotic, but that also are in place stewardship measures to avoid excess and misuse of antibiotics. Also, I was hinting at that before. In many LMICs, the cost for antibiotic are out-of-pocket costs. So we need to take that into account when it comes to producing new antibiotic and when we set, or when the market sets the price for antibiotics, to avoid this barrier. Of course, other issue also comes with unregulated distribution, self-medication, over-prescription, and in general, like global disparities between consumptions. Next slide. I think you can do 4 more clicks, so we take it all in once. So just to summarize briefly, 1 more click. Thanks. Take-home message from my presentation today. Of course, there is so much more to say, but given the time at hand, I wanted to just highlight a few points. So the extreme importance of having global collaboration, both between different sectors, which can be science, advocacy, and practice, but also making sure that we have strong global partnerships. Sustainable funding for innovation. I was mentioning this before. Indeed, it's extremely important to have long-term predictable funding, and not just to overcome scientific and structural challenges that I mentioned before, but also to preserve the expertise, which we know is becoming huge issues in the research sector. Equitable access and responsible use, I just mentioned it, so I'm not going to say anything more about that. Rethinking about incentives and really think about options that are out there that have been tested, like the milestone prices, and really looking into public and non-for-profit models, which are mostly or often most cost-effective and sustainable solution. And last but not least, the shift towards local ownership. We saw a shift most recently, I would say, when it comes to COVID-19, when it's been about producing vaccines and all of that, but we haven't seen the exact same shift when it comes to antibiotics. And that would be extremely important, I think, to move beyond that global north first approach, but really looking into what are the LMIC's needs. Next and last slide. Yeah, thank you so much for giving us the space and the time to talk about this important topic. Thanks.
Thank you, Andrea, for your valuable presentation and emphasizing needs for rethinking on incentives, as Rodrigo was mentioned in his opening remarks as well. Now, in continuation of this topic, let me introduce you to Professor Kim Lewis. He's the director of the Antimicrobial Discovery Center at the Northeastern University.
Pleasure to be here. Can you see my slides? Can you hear me?
Yes, we can hear you, and we could see the slides, but not in the presentation. We can see the whole screen.
Okay. We will fix that in a moment. Okay, how's this?
Online looks good.
Looks good. Okay. Pleasure to be here. So now I will tell you more about basic science of antibiotic discovery. But let me start with this chronology, which very clearly shows where the problem is. So we once enjoyed the golden era of antibiotic discovery, introduced by Selman Waxman, who systematically screened soil actinomycetes for antibiotics. And major classes of antibiotics came from that simple discovery. But then, as you see, something happens around 1960, and the discovery largely stops, as we now understand, because of overmining of actinomycetes. And so the only reliable platform we had for antibiotic discovery, we do not have it anymore. The situation is especially severe for novel compounds from that act against gram-negative bacteria. So quinolone synthetic compounds were introduced in the 1960s, and since then we did not have a novel class of antibiotics acting against gram-negative bacteria. So that clearly tells you where the bottleneck is, right? The bottleneck is not in development. It does not take 50, 60 years to develop a wonderful lead through clinical trials, right? It is getting that lead where the bottleneck is. And so one of the mysteries to me, a basic researcher, is why the majority of resources are poured into development rather than into discovery. But that is something that hopefully is going to be fixed. So then the question is, what to do about this? How to get new antibiotics. And of course, there are two basic sources. There are natural products, and then there are synthetics. And recent advances, I would say, in the last decade are primarily the discovery of new natural product compounds or modifications of natural compounds or compounds inspired by them, rather than de novo synthesis of synthetics. So after overmining the actinomycetes and development of sophisticated tools like genomics and proteomics and combinatorial chemistry, the industry, with the participation of academia, developed this high-tech platform where genomics and proteomics were supposed to give you attractive targets. Chemistry and high-throughput screening gives you compounds against those targets, and rational design, knowing the structure of the target, also feeds into this. And then, result of that a very well thought through platform was closing of anti-infectives divisions in the big pharma. This did not work. We know now why it did not work. It did not work because, especially for gram-negative bacteria, there's a severe penetration barrier composed of the outer membrane and a multi-drug pump that pumps out foreign compounds across that barrier. And the anatomy of that failure was, to their credit, described in these two papers from GlaxoSmithKline and AstraZeneca, detailing how simply screening large synthetic libraries is not going to solve the problem because of this barrier of penetration. So here's a fairly long list of what we would need to arrive at a reliable discovery platform. We would need efficient access to uncultured bacteria that make up the majority of species on this planet, identify attractive taxonomic groups for discovery, efficient screening of environmental DNA, turning on silent operants. 90% of all genes that code for antibiotics don't want to express in the lab. Computational prediction of structures, rules of penetration, this is important. And there's been good work on this from Paul Hergenrother's and Helen Zgurska's labs, how to figure out what properties of compounds favor their penetration. And other such things. This is my wish list. And of course, my lab and other labs are working on this. I will give you, so this is just a snapshot of compounds that we discovered or identified over the past decade. This is only from one lab, right? So there's hope. As you can see, many of these compounds are in development, preclinical or clinical. This one is in clinical development. But the theme, I'll give you one example. I don't want to overburden you. I'll give you one example today. I'll talk about this compound, darobactin, but I also would want to mention a general theme, and that is antibiotics that evade resistance. Because, of course, it would be nice to have an antibiotic to which there is no resistance. And here's an example. Take Surfactant we discovered some time ago, collaboration with Novabiotic. This compound hits immutable targets, precursors of a peptidoglycan. They are not subject to a mutation, and there's no detectable resistance to this compound. It has a limitation. It only acts against gram-positive bacteria. It's an advanced preclinical development. Hopefully, we'll get into the clinic. So one of the very important considerations is where is the bottleneck in this process when you start from soil bacteria, and then you end up with clinical trials. The main bottleneck is actually here at the very beginning, and that is a good source. You know, how to access bacteria that will likely produce something useful. So we're wondering whether there is a bacterial group that has a reason to make antibiotics that match exactly what we're looking for. This is what we're looking for. We want something that acts against gram-negative pathogens, has low toxicity, good pharmacokinetics, and of course in vivo efficacy. And from this short list, this group of bacteria comes to mind, the Photorhabdus symbionts of nematodes. Once they infect insect larvae, the bacteria that they carry get out of their gut and start making antimicrobials to protect that food source. And so they protect that food source by making compounds that have to move through the tissues of the larvae, so have good pharmacokinetics and be non-toxic to the nematode, which means non-toxic. And of course, this is all a systemic infection model, essentially. So screening a small library of Photorhabdus, we discovered this novel class of antibiotics that act against gram-negative bacteria, the darobactins. Very interesting compounds that hit a very attractive target in the outer membrane of gram-negative bacteria. It is an insertase. This protein BAM-A inserts incoming peptides to make outer membrane porins. This target, of course, people have been aware of that target for a very long time. Synthetic compounds do not hit this target. Large screens failed against it, but darobactin stops this target. We know exactly how it does it. It binds to a lateral gate, preventing binding of native substrates And this compound binds to the lateral gates using a backbone peptide interaction. So you cannot mutate the site because any replacement of amino acid only changes the side chains, but not the peptide backbone. This is a very ingenious invention by nature, binding to a target where you cannot mutate the binding site. And so we do get resistant mutants, but that resistance requires the rearrangement of the entire configuration of the protein, decreased fitness, and loss of virulence. So essentially in our hands, the effective resistance rate to this compound is 0 so far. So we have now 2 very different examples of compounds evading resistance, teixobactam and darobactam, which kind of changes the paradigm and the model that we have with considerations of, good stewardship, putting the compound on the back burner, with unfavorable economic consequences that you cannot make money selling antibiotics. So I want to conclude by sort of a simple proposition that finding antibiotics that evade resistance these are going to be rare. And so perhaps the general path forward is a combination, just like you use combination to treat tuberculosis or HIV. I think combining 2 new compounds into one therapeutic is going to largely solve the problem of resistance, where you do not have pre-existing resistance in the population. For that, of course, we just need more resources to pour into discovery of antibiotics. I also want to briefly sort of stress the popular misconception that pulling out of the industry is the main problem, and sort of lack of incentives is the main problem with antibiotic crisis. It is not. There are still big companies in the antibiotic space: Merck, Roche, Shionogi, Basilea. Basilea is now exclusively focused on antibiotics. So if you have a terrific lead, you don't have to worry too much about paying for clinical trials, because Merck and Roche are going to pay for them. Right? It is the discovery where we need to figure out how to pay for. With that, I thank my team, my collaborators, and support, and I thank you for listening.
Send our appreciation from Copenhagen to Boston for your keynote speech, Kim. Now we have our last speaker, again from here in Denmark. Thanks to SSI and Professor Kåre Mulbæk to host this event. Our next speaker represents this institute here. Dr. Ute Wolf Songsen is head of DANMAP, focal point for AMR.
Slides for that. You just push. No. Thank you for hosting me, Carl. Thank you for inviting me. I'll give it a chance. Yeah.
Yeah.
Yes, great, wonderful. Okay, that was my 10 minutes. Yes, I'm going to take you back to the topic of surveillance, which touches very much upon what many of you have said already. Danilo's on the roadmap, Dominique on being worried about the CPEs, many of those things that have been said. So my name is Ute Søngst. I'm a clinical microbiologist by training. I've been heading the Denmark program, the human part of the Denmark program for 10 years. In 14 days, it's going to be 10 years. So that's quite a time. And I'll take you a bit into what the Danish surveillance program is about, but not very much really, because we don't have that much time. The general aim and purpose of AMR surveillance, obviously, is that it is crucial for delivering a fundament and basis for whatever actions you want to undertake when it comes to AMR. They're crucial for visibility, creating awareness, understanding, also sustainability, because you can keep on showing things, the progress and things. They are crucial for national action plans and the monitoring and evaluation. They are very useful for benchmarking, not necessarily crucial, but very useful, particularly if you want to compare yourself to other comparable, let's say, healthcare systems. They're used for treatment guidelines and recommendations, which also leads to antimicrobial stewardship. Then they are really, the continuity in surveillance is useful for establishing the trends over time, which then might mirror changes in demography and healthcare. I will show you a slide on that. And they're also very good for research because they deliver the same way of sampling over time, which might change if you just do research projects. And then in recent years, the shifts in methods from phenotypic AST, antimicrobial susceptibility testing, to whole genome sequencing really has done a change to surveillance systems, and particularly to when it comes to outbreak detection and management, but also to improvement of healthcare management and better IPC. So that's all what a surveillance system should do. And I think Denmark does a lot of it, but not 100%, of course. So what is Denmark? Danilo mentioned it, it was established in 1995. It has 4 main areas. So it includes AMR data from deceased and healthy animals, and clinical isolates from humans. And then it has parts on antimicrobial use and sales data for human and animal sector, in combination with data from several Danish health registers and clinical laboratories. And Christian Müller, when he started talking about building motivation of change in the pig industry, he also showed some very nice figures from the Denmark report. So antimicrobial usage, on the human side, we get 100% coverage of all antibiotics that are sold in Denmark. We get them from the Medicine and Statistics Register at the Health Data Authority, and we can then divide them into whether they were used in the primary care sector or in the hospital sector. If we combine them with other health registers, we are able to look into, let's say, usage per age group. Here I'm showing it's very small, but I'm showing how antibiotics are being consumed in the elderly, and we've tried to compare the elderly living at their own homes to elderly living at nursing homes, and we can see how the usage at nursing homes is much, much bigger, between 50 and 80% bigger than people living at home. Of course, there are also different cases. I mean, there's a reason for them living in a nursing home, but that's a very important place to focus if you want to work with AMR. When it comes to resistance in clinical human isolates, we get 100% of whatever is analyzed out there. We get that automatically in a real-time manner. That is based on phenotypic resistance testing. The upper graph shows you invasive E. coli and their resistance levels. The blue one is resistance to ampicillin, and then the other resistance levels are at the bottom. So you can see Denmark is a low prevalent AMR country, which also makes things easier for us quite often. At the very corner, you see an example of a cluster analysis, because in recent years, we've also just tried to do whole genome sequencing on all the samples that we receive at the National Reference Laboratory. So we are able to do very, very nice outbreak detection. On the animal side, we get antimicrobial usage that actually is delivered from the same medicinal statistics register at the Health Data Authority, but then it's processed through MedStat, which is the equivalent to MedStat. So you have a statistics center for medicines in humans and a statistics center for medicines used for animals, and they are able to break it down into the animal species and also into the size of the animals. And many of you probably have heard about it already. It's a very nice system. Then we record on AMR and indicator bacteria. As you probably know, E. coli and enterococci are really good indicator bacteria because they exist both in the animals and in humans. So the resistance levels are monitored there. And then finally, we also look into AMR levels for Campylobacter and Salmonella and try to compare those across the reservoirs. So we have from the animals, from the meat or food, and from clinical cases in humans. And we're able to divide it into whether those were domestic cases or imported cases, which is also really important for the mitigation and management of it. And then finally, we have in recent years had surveillance of AMR and clinical isolates from animals, and with the focus being on pigs because the pig production is so big in Denmark. So as I said, we have very nice healthcare systems, and so being able to combine our resistance data with the different health registers really enables us to do a lot of stuff. And then there's been all this digitalization taking place over time, so that really fosters both data collection and combination, but it also fosters working with harmonization and quality of data, which is equally important probably. So we have MIBA, which is the microbiology database that collects all results from clinical microbiology testing at the hospitals. They also cover primary care. We have the National Reference Laboratory doing the whole genome sequencing for characterization and typing of the bacteria. We have the Medicine Statistics Register, which I already mentioned, delivering sales of antibiotics. And then in recent years, we've also gained access to a new register, which is called the Hospital Medicine Register. That was developed for financing hospitals, so it's really focusing on the economics, not so much on the usage. And of course, you know, antibiotics are really cheap, so the quality of the data when it comes to antibiotics is really low, but we hope it eventually will improve and be a really good source of data to us. We combine that with the civil person registry, so we know who was sick at what time and maybe hospitalized. We have the Danish Birth and Death Register, which tells us whether the person is still alive. And then we have the National Patient Register, which tells us where was the patient hospitalized, within which wards. And also what kind of procedures were undertaken. Let's see, there's a surgical procedure. All that feeds into the surveillance systems. And in Denmark, we have separated the systems into Denmark, which goes with AMR and AMU or consumption. And then we have since 2015 the HIBA, which is monitoring hospital-associated infections and actually not focusing on AMR, since AMR is quite low prevalent And then at the very bottom, if you're interested, that is a really nice way of working with outbreak detection. We developed a system that is called the EpiLinks, where they're able to track outbreaks at hospital wards. And that way be able to define them, how big is the outbreak, and whether it travels across wards or not. Very, very briefly, here are some examples that combine the different data. So here we have antibiotics for humans in Denmark. That's the total usage. The blue bars are the primary care sector, and the green bars are the hospital sector. You can see how the primary care accounts for about 85%. We can then divide it into the different types of antibiotics, and the blue color that is now dominating the pie chart, those are the beta-lactams, which we are really, really fond of using in Denmark. We have the world championship in using most beta-lactams, so that's nice, having a high proportion of it, but we are also having quite a high usage actually, so I think that needs to be reduced. And in recent years, we've been trying to monitor whether they fit the aware classification or not when it comes to disposition of the antibiotics. We can break down antibiotic use in primary care by looking into municipalities. So here you can see that's the map of Denmark showing you the number of redeemed prescriptions in primary care back in, I can't read it, but I think it's 2016, is that true? Yeah. And then 2023, and you can see that the colors get lighter, which means that they are using less or prescribing less antibiotics. And that applies to all of Denmark. We were able in recent years, due to the pandemic, to monitor antibiotic usage on a monthly basis and compare it to what is happening out there. COVID-19 was a very nice case, because you could see how antibiotic usage dropped markedly, then went back up once the pandemic was over. You can also see that there's a very impressive top that follows, or a peak, and that is due to the group A streptococci, which affected many children in Denmark. And then finally, we can do trends over time, and this to the left is the primary care sector, showing the different antibiotics and how they change. And to the right are the hospital antibiotics, and you can see that there's one blue line that really dominates the picture. Those are the combination penicillins used at hospitals in Denmark, and we really want to reduce the use. So working with rational use in Denmark, we will try to very much focus on reducing the use of combination penicillins. When it comes to AMR on the human side, I very much agree with Dominique. We have a lot to face and to struggle with, and particularly the CPE are increasing in numbers. In recent years, we changed our system for mandatory reporting. So CPE and MRSA are now mandatory to report, while VRE and ESBL positive E. coli from blood are still based on a voluntary system. But changing the Health Act and changing the mandatory reporting system was of great help to us during the AMR reporting, because we're now allowed to combine AMR data with patient register data. We didn't have that before. So how much One Health is there? Because we also listened to some input from the veterinary sector at the beginning of the talk today, and we've tried to divide that into the different areas of a surveillance program. So you can, work with One Health both when you talk about the design of your program. You can work with it when you talk about the sample collection, because you might want to collect samples from both sectors, or maybe even from the environment. You can collaborate on laboratory analysis, data transfer, data analysis, and definitely the outcome communication, because that is really important for both sectors, that you communicate to both. And also your response and prioritization might be somehow aligned and discussed internally, but that's probably where there's least One Health, because that's where you need to go and be very sector specific. There are plenty of integrated analysis examples in Denmark. This is one where we've been looking into ESBL producing and AMC producing E. coli, where we combined the invasive E. coli that were whole genome sequenced with the ones that were collected in animals and in food. And we combined then or compared their resistance types and the sequence types and the source. We could see that the humans pretty much have their own specific sequence type and their own specific resistance types, and the same applies to the animal side. There's very little overlap. Challenges. In Denmark, it is a really positive challenge, but we do have changes in life expectancy. So people live longer. That means there are more people with chronic diseases. There are more people that need to undergo surgical procedures. There might be more people with cancer. That all probably contributes to the rise in bacteremia that we are observing. You can see that it seems to be now reaching a level, but it has been increasing for years. And when the number of bacteremias increase, the antibiotic usage increases, but also the total amount of resistant infections, of course, increases. We also have increases in the number of surgical procedures performed, and that is partly linked to demography and partly not, which is quite interesting and should be investigated. Then, as Dominique said, so I will not spend that much time with it, we have outbreaks with CPE. That is definitely a problem. The interesting part is that when we know that a CPE will enter our hospital, let's say we have a patient from all area in Ukraine, we actually were able to prevent outbreaks from happening because you know exactly what will come into your hospital, you know how to treat it. But very many patients are carriers of CPE or CPOs, and we don't know that until we detect the outbreak. So we're always a bit behind. Then, as I already mentioned, infections in nursing homes, the antibiotic usage in the elderly is quite high in Denmark. It has been decreasing, as you can see. Those are the stippled lines, but there still definitely needs to be done a lot. And I think that the upcoming National Action Plan on AMR will be trying to focus on that. And then finally, which none of you have spoken of, is the lack of access to old antibiotics, which really is a problem. So if we consider that we want 85% of our antibiotics to remain being used in primary care, and those 85% are old, off-patented antibiotics, we need to make sure that they're accessible and that we don't hit shortages. So to the left, you have a report from the Pharmacy Association in Denmark reporting on the number of shortages, and some of these were severe shortages with antibiotics. And to the right, you have an example of nitrofurantoin that had a severe shortage last year, or 2023. And so neither hospitals nor primary care were able to actually get hold of that drug. We also know that there's a problem within Europe, that the buying systems then compete with each other and drain each other's markets, which probably also not is very good. Also, we know that there has been talking very much about stocking, and there's a slight difference between stocking and hoarding, right? So if we come to off-patent antibiotics, we should avoid that they are being bought and then just put into warehouses. So gaps and problems pointed out in recent years, the shortages that I just mentioned, the increase in levels of resistance within the human health sector really demand focus. That is not to say that there shouldn't be a One Health focus, but there definitely needs to be a human health focus. Antibiotics are a common resource for both animal and human sector and should be treated as such. So we need to talk together and find common solutions. And then we know that the intensified hospital activities and food production may lead to higher rates of transition. And that may also raise the question as whether the environment can act as a reservoir. And I think we should put more research and investigation into that. But I don't think in Denmark that is a problem for urban wastewater. I think we should look somewhere else. Will antibiotics save us? Well, maybe if we get a really nice drug, as the one Kim Lewis talked about. But else, I think it's rational use and infection prevention and control that really will do the job. Thank you.
Thank you, Ute, for this important insights and this presentation. Moving forward, we have a Q&A session where you can ask your question to the speakers, but we have to significantly reduce the allocated time since we exceeded the time for the event. But now I can see that Chantal asked Christian that could you tell us a little more about the use of zinc and reasons for its prohibition, and likelihood that the Danes will be able to fold it back in the way described in the slides?
Yes, it was prohibited in middle of 2022, the zinc for use. And we knew that for a long time, so we were discussing what to do, but no matter what we did, it was had this increasing uses of antibiotics. We are now in the discussion with the European Commission also about maybe discussing that about this again, because now it's a lifelong. We can use it still when they get a little older, the pigs. And there have been some. They've been doing something in the Aarhus University where they're looking for that. If you could reduce it quite a lot, the old pigs, and then use a little bit when they're weaned. It's a lifelong, you will use less than now. So I would ask why not go in that direction. Just to reduce the amount of antibiotics at weaning. But so this is still a discussion if we can go forward to that, to make trials maybe again about this. Of course, try really to use it as less as possible, but it doesn't make sense that for now it's a environmental problem. At least we could reduce that totally if you deal in another way. That's what we look for or ask for. Because then we could reduce the antibiotics, I think, quite well, maybe up to 40%.
Thank you. And you can see that Aydilete asked, what is the opinion of the speakers of combining the awareness of AMR with the awareness of sepsis? In national action plans, sepsis is often left out. It's like talking about the risks of smoking without mentioning the risk of cancer. You're hearing from our speakers.
That could be the. Should I stand up or can you hear me? Well, yes, I think yes, of course. The question is a good one. The attention for sepsis is a few years behind the attention of AMR, right? Or let's say the renewed attention. Last year at the World Health Assembly, there was a global action plan on sepsis was adopted, and I think the idea is to bring it in under the attention that AMR is getting right now, which I think makes a lot of sense. There is a lot of overlap. You can see also some of the other speakers mentioned there's other areas that fall under the AMR umbrella that are only just now receiving attention, such as fungal resistance and many other things. So there's a lot of, AMR, I always say there's something for everybody, which means we can expand the bubble of things to include. And I think also having worked in food safety many years ago, we also were looking and clinging on to things that were getting the attention at that point to make our point. And I think this is also what we see with AMR. Not to say that sepsis is not really important in itself, but yeah, it's just one of those things that yeah, need to get attention, needs to get its own attention, but also needs to be dragged by other major issues. Actually, for those of you who are not aware, today is World TB Day. Another one of these issues that actually has a long history, longer than sort of the current AMR wave, if you will. It's been very vertical for many, many years, but it now is also becoming more cross-cutting, as is the greater AMR agenda. Yeah, sepsis is extremely important, and it's good that it's getting the attention that it deserves.
Thank you, Daniel. If there is no question, thank you all participants for your active engagement in this session. Here you can find our call to action on AMR. IDA urges governments, industry, healthcare professionals, researchers, and civil society to adopt concrete evidence-based measures that align with the One Health framework. Our targeted recommendations include for policymakers, governments, and the European Commission that Rodrigo mentioned in the opening remark, but for healthcare and veterinary professionals, our recommendations are implementing and advocating for strict antimicrobial prescribing guidelines to minimize overuse and misuse, and promote rapid diagnostic tools to ensure targeted treatment and reduce unnecessary antibiotic consumption, train and educate practitioners on responsible antibiotic use and emerging AMR threats, and strengthen infection prevention and control and good hygiene practices in healthcare and veterinary settings to reduce infection rates and minimize antimicrobial use. And our recommendation for farming industry is emphasizing the importance of a system-oriented approach in AMR management, considering environment impacts, emission control, animal welfare and animal health, and reduce antimicrobial usage, and focus on the security of supply to maintain consistent access to antimicrobials in low and middle-income countries, and improve animal husbandry practices to reduce the need for antibiotics, emphasizing preventive health care and biosecurity, and facilitate national coordination and collaboration between authorities, industry, and academic institutions to ensure cohesive AMR strategies. And our recommendation for pharmaceutical and biotech industries are investing in novel antimicrobial discovery, supporting milestone-based funding models rather than market exclusivity incentives, and commit to equitable pricing strategies that prioritize access in low and middle-income countries without compromising innovation, and collaborate with governments and international organizations on public-private partnerships for sustainable antibiotic development. And our recommendation for researchers are expanding research into alternative therapeutics, including phage therapy, microbiome-based treatments, and AI-driven drug discovery, and address gram-negative bacterial permeability barriers, a key obstacle in antibiotic efficacy, and advocate for global open access research initiatives to accelerate AMR solutions. And at the end, our recommendations for civil society and advocacy groups are mobilizing public awareness campaigns to educate communities on antibiotic misuse and infection prevention, and engage in policy advocacy to ensure governments prioritize AMR in global health strategies, and strengthen grassroots initiatives promoting responsible antibiotic use in agriculture and community health programs. So today we learned understanding the One Health framework, a comprehensive understanding of interconnectedness of human, animal, and environmental health in addressing AMR. And also we learned about the current state of AMR globally, including its impacts on animal and human health and the urgency for coordinated action. And we discovered evidence-based approach to advocating for effective AMR policies at local, national, and international levels. We also explored actionable strategies for healthcare professionals, veterinarians, and agricultural stakeholders to promote responsible antibiotic stewardship. and be informed about the latest developments in AMR research, diagnostics, treatment alternatives, and innovative practices to combat resistance. We also build meaningful connections with global policymakers, industry leaders, researchers, and advocacy groups working to combat AMR. And we received resources and guidelines tailored to AMR field. And we joined a dynamic network of stakeholders committed to a unified approach in addressing AMR and share knowledge and experiences across disciplines. And we understood the importance of integrating sustainable practices in farming, public health, and environmental management to minimize AMR risk. And finally, we inspired with a renewed sense of purpose and actionable ideas to contribute to the global fight against AMR. And at the end, the IDA will continue its work in supporting research, innovation, and advocacy to combat AMR. We encourage you to stay connected, participate in future events, and take action in your own communities. Thank you for your time, your dedication, and your commitment to global health. We look forward to continued collaboration and process.